Yes. So there's two components to that. One is they're separating people and decreasing the number of people you meet, which is obviously the social distancing. Then the other one is the efficiency of transmission, trying to decrease that by these other methods, as you just outlined. Yeah. So if you can see it as two components, I mean, the lockdown, if you don't meet anybody, then you're not going to transmit it. So there's two components to that, which, as you're quite right, they seem to be rather simplistic, but they do work.
So just outline to me how you see it playing out and what the factors are.
Well, shall I go back to what I've done and what the conclusions of some of my work is and the relevance of that to COVID? Is that a reasonable way of going?
Absolutely. Perfect.
Okay. So initially I set off a few years ago to try and understand TB transmission because we have more TB today than we had 100 years ago. And it seems to be a fundamental of TB, of any disease control, that you want to stop people catching it. And we never really put a focus on that for TB, although we have a tremendous focus on that for COVID-19. And I think the reason is that the response time from getting infected to disease is very short. It's in days with COVID, whereas with TB, it's longer. And that always confuses humans. So generally, people have, for the last 140 years, have felt that TB transmission was only done by the most symptomatic people. And you can see, again, all the parallels with COVID. And the reason for that, I thought, was one, it could be true. The other one could be that you can identify patients with a test which isn't very good. And our sputum test is about 50% sensitive. And then we didn't have any way of measuring aerosols. So we made up the story. So what I thought is, well, let's try and see if we can apply a bit of technology to this. And firstly, try and capture very efficiently what's coming out of people. And that sounds simple, but it isn't, because a cough, which everybody's infatuated with cough, comes out at about 40 meters per second. So to capture that is very difficult. If you cough into a bucket, you'll feel the rebound because the air at those is incompressible. The wave comes straight back at you. So it's not an insignificant challenge to be able to capture that. So we overcame that. We capture coughs coming out at those sort of speeds, and we can capture every other respiratory maneuver, which is less than that. And then we combine that with, let's find a way of detecting the organism which is much better than all the previous ways. So we then developed with colleagues in America a probe which could identify a single live organism. So we could see that it was live and was picking up these probes, and we could look at it on the microscope. So the combination of those changed our whole thinking about TB. So instead of thinking TB, only the most infectious people, the smear positives, are transmitting, we can now identify organisms in a short period of time from everybody that's got TB. And obviously it varies from high numbers to low numbers, but that changes the whole story. So what that then gives credence to is it possible that under certain circumstances, people who are not as infectious can transmit this disease? And then we come to the question of how much air are people swapping with each other? And I would guess, William, you and I are probably swapping about 25 liters of air with other people per day. If you were in Polesmore prison, you would be swapping 2,000 liters with other people. So under those, so what we're now saying is, under poor social circumstances, people who are not as infectious and couldn't infect if you're only transmitting a little, exchanging a little bit of air, could be infectious. And we think that this is probably what's been driving the epidemic in South Africa amongst our poor populations. So that's the background. And then you then look at the parallels with COVID. And the modeling papers are now coming up and saying, well, we think about 80% of cases are probably related to asymptomatic carriage. And that's because this is a relatively short period of time. People can work this out. Well, I believe the same thing for TB, that we can only identify about 30% of TB in our country where we can link it to someone who infected them. So again, I think they're both airborne diseases. I think we can learn something from both. They're not identical, but we can learn some messages from both. So of the work that I've done, probably if I were to encapsulate it, I'd say the one thing that we have found is that the periphery of the lung, that's the peripheral airspace is where pneumonia takes place, particles being produced there and organisms being exhaled there are totally independent of cough or sneezing. So then that's one message. So then we have to see how can we apply those to COVID. And COVID, a lot of our work and our ways of trying to interfere with transmission are based on flu and extrapolating from flu. Well, flu is an upper airway disease. And there is no doubt that if you exhale at very fast rates of 40 meters per second with a cough, you will vibrate all the upper airways from your voice box to the nose and your pharynx. So you will get a sample of upper airway particles. But if our data is looked in, just taking deep breaths can actually produce as many organisms, identical number of organisms from periphery of the lung, which is what we're doing with TB. So then you look at COVID and you look at the sensitivity of the tests that we're using. And there was an interesting comparative test done in China, and they did a throat swab. And I think they found it was between 20 and 30% sensitive. And they did a bronchoalveolar lavage, which is taking a sample of peripheral lung fluid, which is what we do. And that was 93 to 97% sensitive. So it seems, if you apply a sort of little bit of intuitive common sense, that if you want to diagnose a peripherally lung disease, then a sample from there is appropriate. If you want to diagnose an upper respiratory tract infection, then swabs of the upper respiratory are appropriate. But the problem is that this disease does both. It affects it presents with some people with shortness of breath straight away, and that would indicate that they've got lower lung disease. And in China, they did a few cuts on a CT to make a clinical diagnosis, and they said, well, this is our clinical definition. But both of those were peripheral lung issues, and those are the ones that they probably did the BALs on, whereas other people have an upper respiratory tract infection. So this, you have the assay which has a certain sensitivity, but then you have which are the samples that you should be looking at. And my quick answer to that is you should be looking at both. You should be looking at upper and lower. And that's what we've developed the technology to be able to do that.
Now, when you say looking at upper and lower, does that mean two kinds of tests or the same test but with different samples?
You're pretty sharp on that. So what I'm thinking at the moment is that I could, for instance, just get someone to give me 10 deep breaths followed by 10 coughs, and we would get upper and lower respiratory tract sample. Very small quantities. They're in nanoliters that we collect. We measure all the particles, but we think that that would be a great way of getting a sample, and we want to compare that with the throat swab. And we have lots of evidence there to suspect that we will be much more sensitive than because we'll be picking up both upper and lower.
Robert, at the moment the test is a throat swab, am I correct, for COVID?
That's the one that generally, you can do a nasal swab. In China, they also looked at sputum, and it seemed as though the peripheral lung was the highest sensitivity, the throat swab was the lowest, and sputum was somewhere in between, and a nasal swab was better. The problem with extrapolating from those data is they may well have been doing different tests on different sickness, levels of sickness of patients. So they probably only did the invasive BAL on the sickest patients, whereas they probably did the upper respiratory swab, which is much easier to do, on the less ill patients. So there's always biases in these unless they're controlled studies, but it's interesting data to sort of give us an idea of there are two things. One is the sensitivity of the assay itself, and the other is, are we doing the appropriate specimens?
So should South Africa be looking at a different kind of test, and what are the implications of that?
Well, testing has changed rapidly by the minute. So if you look at what's becoming available, there is a test coming in, I think, from Abbott, which is a serological test. That's a test that's looking for antibodies in blood, which is a totally different type of test. It's coming in at, I think, I don't want to be pushing them as a salesman, but it's coming in at a reasonable, affordable cost. And that test is a totally different way of diagnosing the disease as opposed to respiratory samples. So what I've been saying is relevant to respiratory sample testing, but there will be probably blood tests coming in. I know there's another company making similar tests, and they're all racing like mad to get these things out. And but they give us a slightly different view. So what that's doing is looking at an immune response to the organism, a little bit like our skin tests for TB. And that would tell you, well, how prevalent has it been in this community? How many people are susceptible? How many people are no longer susceptible? And that intrinsically is going to be the control of this epidemic. The epidemic will be controlled when the number of people susceptible to it in the population drops. And that's either because they've had the infection or we've developed a vaccine in order to produce that immunity. So my discussion on the bioaerosol and the origins of the sample coming from where the organism is related to respiratory sampling. And the test that we've been using for that is so-called PCR, which amplifies the RNA, the genetic code of the virus. That's the sort of standard that we're trying to increase the numbers of. And it takes a long time to get a result. The blood tests may well, they're on lateral flow devices, which is a bit like a pregnancy test. So those would give answers within minutes or certainly less than an hour, whereas the RNA tests are at the moment taking a day or two, but there are cartridges being made by many companies around the world and being made rapidly, which will do it within an hour or two. So this is a rapidly changing field, and we need to make an idea of which are likely to be the most successful, and then they need to be scaled up, because essentially we've got two ways of tackling this epidemic. One is the social distancing and decreasing the efficiency of transmission between people, and the other is actually finding out who's got the disease, who's transmitting it, and targeting towards those people. And that'll probably be a combination of respiratory sampling and blood sampling.
And the point that you make about that your research has shown it's not just cough or a sneeze, but it's actually just breathing that enables this aerosol transmission. What are the implications of that for practitioners? There's all this, there's this discussion at the moment about whether doctors should be seeing people at a first contact point, or whether it should be a tele consultation and then people channeled accordingly. What is your view on that?
Well, I think it's incumbent on the medical profession to deliver their medical care. If they can do it efficiently remotely, then that would be preferable. I think America's hit this crisis of personal protective equipment, and they've run out of it, and they're using masks multiple times instead of once. To my mind, I'm quite taken by the number of medical people in China. The first person who recognized the disease died of the disease. So there is transmission taking place between patients and staff that actually know about this. So I think giving them the appropriate and proper personal protection is key with personal intervention. So they should not be using inadequate masks multiple times that are meant to be used once. They should be in well-ventilated areas, and if they can do it remotely, that's fine. So my view is that N95 masks do need to be used and given to protect our medical staff, because they're the front line of our ability to cope with this epidemic. And unnecessary consultations are obviously need to be minimized. And if things can be done remotely, that's also fine. But I don't think that's ever going to be a total substitute for meeting patients and interfacing with them at close quarters. And under those circumstances, we need to give the best protection to our medical staff as possible. And you see that even in the richest country in the world, in the US, they're using inadequate masks multiple times because they don't have enough equipment. So there is an urgency, to my mind, to get testing and protection equipment for our medical staff.
But when you use that staggering comparison of 25 liters a second if we sitting talking to one another, but in Posmo it would be about 1,000 times higher than that, or 100 times higher than that. So basically sitting in a minibus taxi is going to be a bit like being in Posmo prison.
A little bit. I have actually looked at that. Interestingly, there are two components to this. One is the crowding, number of people you've got, the amount of air that you're swapping, but time is also a big factor. And it so happens that in minibus taxis, they open a large part of the side of it at regular intervals. And the time that people spend in minibus taxis is relatively short. They spend more time in train travel and bus travel. And obviously the big risk is, if you're in a minibus taxi going between provinces, that would be very, very high because the total amount of air that you will have exchanged with other people would be very high. So it's a little bit complicated. There's a number of people in the space. There's the ventilation of the space and the time that you spend in the space. So three components really. Now in prison, everything's against them. They're crowded, there's no ventilation, and they're there for 23 hours a day.
Yes. Tell me about ventilation, what the factors, windows, air conditioning, how does that all affect the transmission rate?
Well, again, there's not a lot of experiments directly on this, so we're sort of extrapolating from other experiences. But if we had two forms of transmission, relatively large particles, which can be accelerated in a cough at somebody else, then ventilation is not going to make as much difference to that. It's preferable to have it, but if there's direct large particles being extruded at very high rates, that's where the 2-meter rule comes in. If we're talking about small particles that can remain airborne for long periods of time, then ventilation makes a massive difference to that. And then air conditioning units vary in different systems. They can be HEPA filtered. So if you were to buy the top of the range Volvo, I went around their factory looking at their air units, they recirculate and filter air. So there are different levels of safety for air conditioning. Just recycling air is not a good idea, and cooling it. The amount of fresh air that's coming in that's diluting the sample is important, and that can be diluted by many ways. It can be diluted to some degree by ultraviolet light. Yes. That almost makes it the same as ventilation. You can put fresh air from outside, or you can filter in the air conditioning system. So they are all ways of removing the particles from the air, and that obviously has some benefit. The next thing is how infectious and how is the particle, how able to survive in the environment is it, and how many are being produced by individuals per litre of expired air or whatever it is.
Robin, does that mean that
can I just go back one thing, just to, because it may get, you said just breathing. Now, I've been very careful. So what happens is the particles are produced in the periphery of the lung when, because they close down as you breathe out, and then they open up and pop because they're covered in a sort of detergent. And that's not necessarily, I wasn't saying normal breathing. If you breathe very slowly in and out, then that doesn't produce a lot of particles. But if you take a deep breath out and then a deep breath in, that will produce the same as a cough. And in fact, when you cough, you normally do take a rapid inspiration just before. It's that which produces the peripheral lung particles. So I don't want to scare people that just normal tidal breathing, and to some degree speech, because you modify the speeds when you speak. So speech and tidal breathing are not deep breathing and coughs are the same. So it's just illustrating that a cough is not necessary, that the breath before the cough is probably what's producing it. Sorry, that was just to sort of clarify that.
No, sorry. To come back to this thing of air movement. So
Yep.
A desk fan is probably not a wise thing. An open window is preferable.
Yes, open windows are quite interesting. That if you open a window on one side of a building, you don't get you get hardly any ventilation. If you open it on both sides of the room, then you get cross ventilation dependent on the wind velocity of the side that's open facing the wind. So it's highly variable. In the old days, we used a lot of thermal ventilation. So I don't know, when you were in old-fashioned classrooms, they tend to be very tall and they had windows up at the top. And that's a different type of ventilation, which is due to the heat produced by individuals, has a sort of Venturi effect of moving up and taking it out. So ventilation is something which we've sort of forgotten about over the last 100 years. We now build buildings because of their cost effectiveness and their heat efficiency. But in the, if I went back to the 1920s and looked at ventilation in New York classrooms, and they were excellent. But they had these high windows and there was an emphasis on ventilation. Hospital wards were so-called Nightingale wards, were very high ceilings. And that, of course, increases the volume and dilutes the particles in there. So it seems as though we have lost a lot of that knowledge and ignored it to our peril, because I think that's not good for respiratory transmitted diseases.
You spoke of the role that ultraviolet radiation can play in this. There's been the speculation that one of the reasons that Africa has not as yet recorded such high rates of infection because of the climate and the heat and the sun. What's your view on that?
I think that it's an interesting theory. The data, at the moment, looks as though that's not the case. That this virus may be less dependent on those type of things. The other thing is, I believe that most of the transmission is taking place indoors. That as long as you're not too close to people outdoors, it's not going to, the small particles aren't going to transmit between people. Infectious diseases usually are related to indoor. And obviously weather changes our patterns of behavior. We tend to close the windows on our cars or minibus taxis, and we tend to crowd together inside. This virus, at the moment, there's not enough data to have a lot of hope that climate will make a big difference, but time will tell. People are looking at it, but the feeling is that it's probably less impacted by environmental conditions than the seasonal flu. But really, it's been a little premature to either put too much hope on there or to be too pessimistic about it. But we will see in the next few weeks what happens in South Africa. And if we follow the trajectory of the countries in the Northern Hemisphere, so it's speculative, but I don't think we should not do everything we can in the meantime on the hope that, oh, well, it will get better, it won't transmit in our... So, and the other thing is we are coming into the flu season anyway in the next 2 or 3 months.
What is your view on the zero death rate in South Africa so far? Is this a statistical anomaly? Is it going to suddenly jump up? What's happening there?
Well, we're at the very beginning of the epidemic. If you look at the age, until recently, the age of all the patients was given, and the majority of the patients were travelers, or the people who were infected were travelers sort of in their middle ages and not elderly people. So the factors that affect mortality are going to be the portion of the population that's getting infected. So if you go to Mardi Gras in New Orleans, you can guess that it's going to be youngsters. If you go to an old age home in Seattle, it's going to be oldies. At the moment, the epidemic has been predominantly imported people from international travel, and they've been relatively young, the death rate takes off, particularly above the age of 60 to sort of 80s is where it really takes off. And death rate is going to be related to those factors, and also to the availability of healthcare and the overwhelming of healthcare systems. That would also increase mortality. At the moment, I think it's very good news that no one's died, but it's not surprising. This sort of data has occurred in the early epidemics elsewhere. And the next few weeks during this close down will let us know, one, if we've been successful in stopping that. But if we haven't, the death rate, I'm pretty sure, would increase. And these comparisons between countries are tricky because it's the state of the epidemic, the availability of healthcare, the portion of the population that's getting infected. I mean, in Europe and Norway, for instance, I think most of the Norway cases came from a skiing holiday in Austria. So that just changes the demography. So all these things need to be standardized by age. You need to have standardized ways of collecting them. At the moment, people who are dying of TB, of which there are, there's always some. How do we know that they're not COVID? We're not testing. So the testing availability also changes that. But anyway, it's good news at the moment. But I think the experience of other countries would suggest that we don't take too much encouragement from that.
I might very well be cut off from you soon because I'm on a different package. But I just want to ask you about the expectation has been that because of South Africa's high HIV and TB prevalence, it's going to be particularly vulnerable. I've heard someone suggesting that it might be that the opposite, that people who are on antiretrovirals may in fact be less vulnerable to COVID-19. What's your views on that?
Well, I think as a nation, one of the things we've got in our favor is that we're a relatively young population, much younger than Italy, for instance. I think a very large percentage of our population are under the age of 7. So the impact at a national level could well be much less. And then the factors that you say, HIV, in Europe, they've been looking at that fairly carefully, and it doesn't seem to be a major factor. You're postulating it could be a protective. I don't think we've got enough data to say that, but the feeling is that HIV individuals on appropriate antiretrovirals are not a particularly excessive risk compared to the rest of the population. Obviously, age is probably more important as your risk. The TB one is fascinating, and it's something that really concerns me. There was one little bit of preliminary data from China to say that there may be some link between the two epidemics, and certainly I think that it's an interesting area of research to see very early on if there is a link between those two, because we do have the highest TB rates in the world. Airborne disease, and it'd be very important for us to look to see what the prevalence of COVID is amongst that group of people. And the other problem is, of course, they're presenting with almost identical symptoms. So you get a fever, shortness of breath, and body aches, and we have to distinguish between TB and COVID. And I think the logical thing is we're going to have to get the tests to test people appropriately for TB and appropriately for COVID, because they may have either or both. And that, I think, is potentially something that South Africa needs to look at very carefully and is in a better position to be able to answer.
Does it mean that, given the difficulties of identifying and also the relatively short span of COVID as it unfolds, that we'll really only have a statistically accurate picture maybe 3 years down the line, in the sense that many people may have died of, or appear to have died of, one infection, but in fact it may well have been a COVID infection?
Well, and I don't see why it should be 2 or 3 years down the line, but I mean, I think what it means is that we have to put a major effort into testing. And the problem is that we obviously started with very few tests, and I know that there are efforts to increase the tests. As I pointed out, the biotech companies around the world are also increasing the spectrum of tests. But I wouldn't be quite as pessimistic as that. I think that we need to access these things and apply them straight away, so we get answers certainly faster than the time frame that you were sort of indicating there.
Yeah, it'll be more months rather than years, basically.
We've got a moving target, and we're trying to measure aspects of that moving target. And you've seen the graphs from other countries; those graphs can be quite scary early on in the explosive stages of epidemics.
What's your gut feel how it's going to play out in South Africa? Are there things that are not being done that we should be doing? Are we doing some things incorrectly?
I think the big thing is we're not testing enough. There are logistic and reasonable reasons for that, so you can't point fingers. But I think that is a major emphasis that we should be targeting. I think there are some things that perhaps weren't thought through. The secondary consequences of laying people off, and I'm aware that the taxis going between provinces were full of people. That's what we did in 1918, and that's why we had double the mortality rate that happened anywhere else, because we disseminated the virus very rapidly. So I think that we should have protected the rural areas from the epidemic in the cities rather than sending relatively young people back and forth. I think the emphasis is on protecting older people. Is our key thing. I think on the positive side, we have a very young population. How effective distancing strategies are living in very poor conditions, I think there's no experience in the developed world about that, and I think those are the things that would concern me and that we should be particularly focusing on. But I think my highest priorities are to protect the elderly, and if they're sitting in the rural areas, we should have given them supplies and kept them there. People in old age homes, I think we have to protect our healthcare system because it is going to be stretched. And we're not the wealthiest of countries, we're a middle income country. So we have to preserve our resources, and our medical staff are a particularly important resource. And then the effectiveness of distancing strategies. I think to some degree, the reason we use them is because we don't, it's such a blanket thing. It's because we don't understand and can't identify the sick and the transmitters. So therefore we take the whole population and try and apply something which seems intuitively the right thing to do. There are always secondary unforeseen consequences of that. When you close a school, we've been looking at nutrition changes. Kids were getting their meals. Are they all going to go and transmit the disease to their grannies? Those are all the difficult things. But on the other hand, I think that having seen the explosion of the epidemic in other countries, it's not unreasonable for our leaders and politicians to try and do the fastest, easiest thing to do. Will it always be, in retrospect, the smartest thing? Could it have been refined better? I'm sure that's always going to be the answer is yes. But no, I'd support the idea. The concept of flattening of the curve is interesting, but we're really trying to buy time for our health system and for our old people to be able to get a vaccine in maybe 18 months and not be infected in the meantime. So it's complex. It's easy to throw stones at specific idiosyncratic bits of the program, but I think in principle it's the right way of going.
Thanks very much, Professor Wood. I just wanted to ask you now, while we're still speaking, are you okay to, once we use this, perhaps next week, to spend another 30 or 40 minutes taking online questions from practitioners?
Yes, I'd be happy to do that. Obviously, I'm a researcher rather than, although within the organisation we do a lot of treatment, and we're trying to develop an emergency plan at this moment. But certainly, I'm happy to give my time. Whether it
Oh,
needs to be balanced by someone from the NICD or something like that is, you can decide on that. But it might be mine is. I think most of what I've said is sort of targeted at medical people rather than the lay population.
yes.
So yeah, so I'd be happy to help with that as much as well as I can do.
Oh, fantastic. Thank you so much. It's been
Thank you.
incredibly
Oh,
kind of you to put the time aside.
pleasure.
Okay. Cheerio then.